Hi, my name is Zoe LaPier. I am an associate professor of obstetrics and gynecology and a urogynecologist here at UT, and I'm going to be lecturing you on recurrent urinary tract infections, or RUTIs, how you will see it abbreviated. I have no financial disclosures. The learning objectives for this presentation is to define and diagnose an acute uncomplicated cystitis, to look at the treatments for UTIs, to define what recurrent UTIs are, how we can prevent recurrent UTIs, and then also just review what asymptomatic bacteriuria is. So the scope of this issue is quite large. 60% of women will have at least one UTI in their lifetime. 3 to 10 million ER visits annually in the US are for UTIs alone, and it's estimated that about $10 billion annually of healthcare costs are spent on UTIs alone in the United States. So we spend a lot of time and money on this one issue. So to define what a UTI is acute uncomplicated cystitis. I'll call it a UTI just for simplicity's sake for the rest of the lecture. It is an acute urinary tract infection that is isolated to the bladder in an immunocompetent host or individual, and it means that they also don't have things like fever, they don't have systemic symptoms, they don't have flank pain, they don't have CVA tenderness, and also this is a big one, they are not male. By definition, male bladder infections are considered complicated, and so this whole lecture is basically just going to be pertaining to female UTIs because that is the definition of uncomplicated UTIs. So, what is the natural progression of a UTI? So, most cystitis or UTIs are self-limited. We can expect that about 50% of women who have symptoms will actually self-resolve those symptoms within 3 days. There was a Swedish study of 752,000 women who had UTIs. 55% of those women never picked up their antibiotics and never had any within that study. The risk of pyelo, which is the thing that we're always worried about, is that will this UTI progress, was pretty low. The women who didn't pick up the antibiotics had about a 1.4% risk of progression to pyelo. With antibiotics, that risk of pyelo progression was much lower. It was about 0.2%. And so overall, antibiotics have been shown to decrease the risk of hospitalization for pyelonephritis by 45 and 49%. Obviously, that's a little bit different than the 0.2 and 1.4. That's the difference between outpatient treatment of pyelo versus inpatient treatment of pyelo. So my question is always, for at least my trainees, why do we treat cystitis or UTIs? This is obviously in the non-pregnant individual. We treat it to prevent pyelonephritis and for symptom control. It does decrease the number of the risk of formation of pyelonephritis and also hospitalization for pyelonephritis. It also really decreases the symptoms and shortens the durations of the symptoms for these patients. These symptoms can be quite debilitating. They can prevent people from going to work, from being fully productive members of society, and they just feel miserable. So, let's talk a little bit about who's at risk for a UTI. Women, anyone who's female. Anyone who has a history of a UTI, whether that is a personal or family history. If you had a UTI earlier than the age of 15, or your mother had a UTI earlier than the age of 15, you are more likely to get UTIs in the future. Recent sexual intercourse puts you at risk. Diabetes, especially poorly controlled diabetes, structural abnormalities, urologically, menopause, and other lower hormonal statuses. So if they're on medications that inhibit hormone production, Lupron, things like that, that can also promote and make it more likely to get UTIs. Catheter use, and then just anatomy in general. There are studies that show that there is an inverse relationship between the distance between the urethra and the anus and the number of UTIs that you get. This is obviously a non-modifiable risk factor. So how do we diagnose a UTI? You have to have all three of these things. You need to have the symptoms, you need to have inflammation on a urinalysis, and you need to have a positive culture. And I review this with my patients frequently. For symptoms, you're looking for things like, dysuria, frequency, urgency, nocturia, hematuria. You're also looking to rule out things like fevers, rigors, vomiting, back pain. So you're trying to rule in things that are basically isolated to the bladder and rule out things that could potentially indicate things that are more systemic or kidney involved. The FDA says that you should have at least 2 of the symptoms to define as positive for symptoms. And then inflammation, the urinalysis. This isn't, you should show some pyuria. And so the FDA and the European Association, they recommend that they say pyuria is defined as 10 lukes per high powered field. There are also some associations that say many bacteria can also be considered for inflammation. A little caveat with that. That can also be from contamination or other things like that. And then the culture. You need to have a culture for a pathogenic organism. This means an organism that will actually cause a bladder infection and not another organism that's like a skin bacteria, vaginal colonized bacteria, one of those. The FDA does say that it needs to be 10 to the 5th CFUs or 100K CFUs for it to be a positive culture. There is some literature that shows that, especially for catheterized samples, you don't need 10 to the 5th to meet criteria. And then there are also about 15% of patients who won't actually meet that criteria, but likely do have UTIs. They have the inflammation, they have all the symptoms, but they don't quite meet greater than 100K CFUs. And we will oftentimes treat those patients too. But this is kind of good guidelines. If you're having cultures that are coming back with GBS, lactobacillus, standard staph, not Staph saprophyticus, but staph, things that colonize the skin, those are contaminants, not actual infections. So when we're talking to our patients about symptoms, that's why they come in. How reliable are these? So in a systematic review of about 3,700 patients, they tried to look at the correlation between what symptoms they presented with and did they end up having a positive culture, and at what level of positive culture. Was it 10 to the 2nd, 10 to the 5th? They looked at all of that. And so it was really just to see how predictive were their symptoms. They found that dysuria, frequency, urgency, hematuria, those were kind of the big ones as being the most predictive. A single individual symptom was not super predictive of a UTI. Hematuria alone, this would be gross hematuria because it's a symptom someone can see, was the most predictive of a UTI as a single symptom. And so that can kind of guide you. When you had multiple symptoms together, when you had dysuria and frequency and urgency, you had a much higher sensitivity. When you don't have dysuria, when dysuria, frequency, and urgency are all missing from the symptoms that a patient is having, the likelihood of a UTI is very, very low, like less than 10%. Once again, also kind of on that kind of ruling out a UTI is that if someone's saying that they have vaginal discharge, that actually decreases the likelihood that they have a UTI as well. So we get the symptoms. Next thing we do, we get the urine dip. Most people have these in their office, whether you're dipping them and looking at them with your eyes or whether you have the machine that reads them. Really on these, we're looking for the 3 things. We're looking for the lukes, we're looking for the nitrates, we're looking for blood. And in this case, for nitrates, we're looking, these are bacteria that convert nitrates to nitrites. These kind of bacteria, E. coli, Proteus, Klebsiella, they are all nitrite producing bacteria. You can get false negatives with this. So if you have bacteria that aren't nitrite converting, like E. coli, then you'll get a false negative. Also, if you have someone who has a diet that is very low in nitrites, then you'll get a false negative. Leukoesterase, the first line that you see, just kind of is a proxy for the white blood cells. It can be falsely positive with vaginal infections. Vaginal contaminant can turn this positive very quickly. Any kind of inflammation can also turn this positive. Cancer can turn this positive as well as kidney stones. Catheter, if someone is using a catheter or has recently used a catheter, this can also be falsely positive. And then blood. This actually doesn't test blood. It tests for peroxidase activity. Um, and, this is also a good indicator. And you can get false positives with this. I would say the most common one that I see within the UTI community is that you get it with phenazopyridine, which is also pyridium, or azo over the counter, azo bladder pain relief. So, make sure you're getting in the history. Did they take any medications? Because if their urine is fluorescent orange and they took some azo, this will be falsely positive. It can also be falsely positive for myoglobin, but I think that's less common than just azo. So, how accurate are these dipsticks? So, there was a systematic review that looked at, can you use dipsticks to exclude a UTI? And the big takeaway from this study was that if someone has a high pretest probability, meaning they come in with symptoms and they have like 4 or 5 of the classic UTI symptoms, and they have a negative dipstick, it's still recommended that you send that out for a culture. That can be falsely negative on a dip. Especially if the patient has been really, really hydrating, it can kind of dilute everything and really kind of mess up with your dip. If you have a dip that has hematuria alone, that is the highest probability and the highest diagnostic utility on the dip. When you start getting multiple positives on your dip, that is the best post-test probability that you have a positive culture. So if you get hematuria and nitrates on your dip, you have a 93% chance that's probably going to end up being a positive culture and positive UTI. And so really this is, this study, there was a lot of heterogeneity within the results in all the studies that went into the systematic review. But pretty consistently, like if you have, very consistent symptoms, just send the culture, no matter what the dip says. It's helpful whether it's positive or negative for different reasons. And then when you have dips that are positive for multiple things, for hematuria and nitrites, for hematuria, nitrites, and leukoesterase, then those all increase the likelihood that your culture is going to come back positive. And the question is, what is that going to come back positive for? Your pathogens, things like E. coli. E. coli is going to be your number one. This is 90% of all UTIs. Other common ones, Klebsiella, Proteus, Staph saprophyticus, and Enterococcus. All of these are very, very common, forming UTIs, but the one that you're going to see the most is E. coli. And we're usually looking at uropathogenic E. coli. This is an E. coli that has, adhesins. They have special pili that help adhere to the urothelium. They adhere to the oligosaccharides, and they really help grab onto that urothelium. They really allow it to attach to the urothelium, form a biofilm, create an infection pretty quickly. And oftentimes these symptoms are pretty short in onset. Like patients go from having no symptoms to horrible symptoms really, really quickly with this bacteria. They also oftentimes they have a flagella, which will help them travel. That helps them get up the urethra, helps get up sometimes into the, up the ureters, into the kidneys as well. This is the most common thing that you're going to see. And treat. And so how do we treat these? With antibiotics. For acute cystitis, we recommend, for first line, it's recommended that you treat with nitrofurantoin, trimsulfa, or fosfomycin. The fosfomycin was treated just once. All of these doses, you see nitrofurantoin's for 5 days, trimsulfa's for 3 days, fosfomycin's just a one-time dose. These are all very short courses. If you're treating a simple UTI, you don't need a long course, nothing longer than 7 days. The Infectious Disease Society of America recommends that if you are treating empirically, that you don't use trimsulfa if your region has a resistance of greater than 20%, which I always think is a little hard because it kind of depends. You don't know what bug you're going to get going into it, but I guess you can use E. coli as a proxy. Second line treatments that you can use ciprofloxacin, which is a 3-day course, cefpodoxime, which is a 5 to 7 day course, and then amoxicillin clavulanic acid, which is also a 5 to 7 day course. If you're considering sending phosfomycin and you're worried about resistance, and you're thinking that you may do that, when you send the culture, you need to write a note to the lab saying that they need to test for fosfomycin sensitivity, because that is not something that we routinely do here in the United States, because it's not a very routinely prescribed antibiotic. They will test for it if you ask them to. And we don't have a lot of resistance to fosfomycin. It's pretty uncommon just because we don't use it that often, but it is a very, very good one-time medication to help treat. So, these are how you're going to treat this, but what do you do while you're waiting for that culture to come back? Because there is a lot of debate and a lot of heterogeneity in how people approach this. The AUA, SUFU, EUA, SCOG, they all have moderate, strong recommendations that you can, in patients who just have, a one-off UTI, that you can have them self-start an antibiotic. CEMIC is a little bit more prescriptive, and they say only self-start antibiotics or empiric treatment of antibiotics in patients who have less than 3 UTIs a year. All of these organizations recommend the symptomatic management of UTIs. So if you're opting to hold off on treatment until you get the culture back, you should be symptomatically managing them. That means that you should be giving them things like, offering Tylenol, Pyridium, things like that can help manage their symptoms until you can get those culture results back. Obviously, this is not applied to patients that are pregnant. And then all of these societies exclude patients over the age of 65, which is sometimes very challenging since a lot of our patients who have UTIs are over the age of 65. For me, what you do while you wait for the culture, I tend to land in the symptom management group. I like to wait for the culture for this reason. This is the antibiogram for University Hospital. And as you can tell, we have a lot of yellow and red. In E. coli, there is a lot of yellow. There's a lot of resistance. And so, based off of the Infectious Disease Society, they would say we should never be empirically treating UTIs with Trimsulfa. It's almost a 30% resistance rate within our community. And, the two most common bacteria, they both have greater than 20%. So I tend to favor waiting when at all possible to treat. And I'm very upfront with my patients about this. There was a study that showed that when you're treating with empiric antibiotics, you have about a 25% chance that you're calling that patient back in 3 to 4 days saying, hey, I gave you the wrong antibiotic, I need to switch it, and you need a second round of antibiotics. More resistance, more symptoms, or more side effects from the antibiotics. This isn't unique to San Antonio. This is all over the country. Whenever you can wait and it's safe to wait, I tend to recommend doing that. And then what do we do with our patients with, a recurrent urinary tract infection? Those are all just kind of one-off how to treat a UTI. We're going to get into the nitty-gritty of recurrent UTIs. So what is a recurrent UTI? By definition, you need to have 3 UTIs in 12 months or 2 UTIs in 6 months. These are supposed to be culture-proven UTIs. I like the way that the AUA and SUFU describe this. They say culture-proven episodes of acute bacterial cystitis and associated symptoms. So to me, what that means is you need to have the 3 things that I was talking about. You need to have symptoms, you need to have a urinalysis that's positive, and a positive urine culture. And you need to find those things to make sure that those are truly all positive to treat for UTI, to call it recurrent UTIs. Recurrent UTIs are pretty common, especially if you're using the 2 cultures in 6 months definition, because about 25% of young healthy women who have one UTI will develop another one within the next 6 months. And what do we do? How do we approach recurrent urinary tract infections? Pretty similarly how we approach anything else clinically. First you get a really good history. You figure out, are these truly UTIs? Do they have symptoms and positive cultures? Do they have all 3 of those criteria? What are their symptoms? Are they UTI-like symptoms, or are they having vaginal burning and vaginal discharge? What happens that causes UTIs? Is there anything that happens before the UTI? Are they having sex with a new partner? Are they having sex in general? Do they have episodes of decreased PO intake for fluids that would predispose them to a UTI? Are they traveling and not peeing frequently that would predispose them to a UTI? Are there other things in their history that could predispose them? Things like fecal incontinence can be a big one, especially in our elderly population. Are they having, are they having multiple episodes of diarrhea? I also think sometimes vulvar hygiene questions can be helpful. If everything else is kind of coming back negative, making sure that they're not douching, that they're not using any sponges or anything to clean inside the vagina. All of these things can be very helpful to kind of elucidate in your history. You should also be looking at the urine testing. Ideally, there are urinalysis and cultures that are available. Hopefully, someone has done urine testing and hasn't just been sending antibiotics every time someone has symptoms. That gets pretty confusing. You can't really diagnose it at that point. If you have cultures, do they have resistance? You'll also in the history make sure that they don't have any red flags, like they're not being admitted for pyelo, they're not, nothing like that that's going on. No history of kidney stones, those kind of things. And then, once we've done kind of our routine history, looking for urine testing, what are we going to do? Ideally, we want to prevent these infections. We want to keep these from coming. And how we do that is usually kind of a multi-step process. The things that have been the most proven to prevent infections are prophylactic antibiotics. This can be either daily or postcoitally. Other things that have been very helpful that are non-antibiotics are vaginal estrogen and increasing water intake. And then mixed data, cranberry supplementation is showing more and more promising, can almost be moved up to the proven benefit category. D-mannose and methenamine has some mixed data, but they are recommended by general societies for preventative techniques. So kind of going through from the most proven to the least proven. Antibiotics. They are the most effective way of preventing recurrent UTIs in patients with recurrent UTIs. They can be daily or postcoitally. In a randomized control study that compared postcoital versus daily in patients who had intercourse-related UTIs, there was no difference in their efficacy. So if you have someone who just has postcoital UTIs, just treat them postcoitally. Oftentimes, if you're talking about initiating a daily antibiotic, you're talking daily antibiotic for 3 to 6 months. And then that you reassess, and then you can kind of wean off the antibiotic. There are a bunch of different ways that you can do this daily antibiotic based off of allergies and, prior resistance patterns if you have that. Nitrofurantoin is a great option for patients who have appropriate kidney function. You can do trimsulfa. Those are kind of two of my favorites. Fosfomycin is also great. You do that once every 10 days. You can also use cephalexin, or you can do Cipro twice a week. And so these are all good options if you need to get to that. I personally I use antibiotics daily, but whenever I can, I try to do my non-antibiotic treatments and preventative measures first. And so for me, within my population, the number one thing is vaginal estrogen. A Cochrane review did look at this, and it showed that vaginal estrogen does decrease the rates of urinary tract infections, but oral and transdermal does not. So if someone's coming in on menopausal replacement therapy, like an oral estradiol pill or an oral or a patch, that is not going to prevent the UTIs. That has not been shown to help decrease the number of UTIs. Only the vaginal estrogen cream has. The way this works is that it actually promotes lactobacillus formation within the vagina, which is a common bacteria that is usually present prior to menopause. The lactobacillus really lowers the pH of the vagina, which makes it less hospitable to pathogens and prevents the infections. There is no dosing that has been shown that this dose is better than that dose to prevent UTIs. I start with the standard GSM kind of dose, which is 1 gram of estradiol inside the vagina twice a week, and I dose it at night before they go to bed, so you get that absorption before they get up and it all kind of runs out. a couple things to keep in mind with this dosing is that UTIs are not considered a indication for vaginal estrogen, or UTI prevention is not considered an indication for UTI prevention by the FDA. So it is considered off-label, and oftentimes if you code it for recurrent UTIs, insurance companies will not pay for it. So keep that in mind. They will pay for it if it's for GSM or genitourinary syndrome of menopause, because that is what it is approved of for by the FDA. So the thing that you're going to get asked if you bring up vaginal estrogen or any kind of hormone is it safe? Is it going to cause me to have breast cancer? Things that you can expect to see as far as side effects for your patients. You can expect some breast tenderness in some of the patients. You can expect some vaginal irritation and burning, especially if patients have a lot of atrophy. The first few times that they do the creams, they can get some irritation and burning. Usually that goes away within 30 minutes. You can get non-physiologic discharge, which is really just the medicine coming out. And you can sometimes get some vaginal spotting and bleeding. If this does happen and they have a uterus, it needs to be worked up. Overall, the question of is it safe? The answer is yes. On the right-hand side is the warning that is carried on all of these low-dose vaginal estrogen supplement suppositories and creams. It's unfortunate it's still on there as of today, which is September the 30th. There is the FDA recently had a large panel of experts that convened, and they heard from experts across the field that are petitioning to get this black box warning removed. Vaginal estrogen cream at low doses has not been associated with increased rates of endometrial cancer. It has not been associated with increased rates of breast cancer. It has not been associated with increased rates of thrombosis formation. It is a very safe thing. Vaginal estrogen cream also does not raise your estrogen level beyond the postmenopausal range in patients who are postmenopausal. In patients, they've done lots and lots of studies on patients who have used estrogen, who have breast cancer or have a history of breast cancer, and it has not shown an increased rate of recurrence in patients with a history of breast cancer, especially when you're dosing it below the 10 microgram. Some of the studies showed that there's no association. A couple of studies showed that the dosing might matter when you have 25 micrograms versus 10. And so if you have a patient with a history of breast cancer, even estrogen receptive positive breast cancer, you can prescribe vaginal estrogen. Oftentimes, a quick message to their oncologist is appreciated. And if for no other reason, just to get the patient on board. But this is a very, very safe thing to do and a really good way to prevent infections in women. This can reduce the number of infections by 50 to 70%. And so I love vaginal estrogen. It's my number one thing that I recommend for recurrent UTIs in postmenopausal women. There are a lot of different formulas that you can offer. There's a generic cream, there's a brand name cream. There's no studies that one works better than the other. The generic's obviously usually cheaper. You can get it online for really cheap, even without insurance. You can get it anywhere between $15 and $30 a tube that'll last for 3 months. There's suppositories that you can use 2 times a week, and there's also rings that go in and stay in for 3 months. The rings are great for patients who can't remember or don't have the dexterity or the ability to apply it themselves. One thing to keep in mind with the vaginal estrogen cream is that it does not start preventing UTIs right away. You have to give it a couple months. You have to give it about 2 to 3 months for it to start to prevent the UTIs. And so if you start it, let the patient know that they may still get another UTI in the next month to 2 months, and that doesn't mean it's not working. It just means that we have to give it time. It is a very low dose, so it does take a while. And the question is, when do you not start vaginal estrogen? Most people you can. When do you not do it? You don't do it if they have abnormal bleeding from the vagina and the uterus. If that has not been worked up, don't start the estrogen until their gynecologist works it up. If they have active endometrial cancer, don't give them vaginal estrogen. If they have a recent history of endometrial cancer, I would definitely reach out to their gynonc before you consider giving it to them as well. If they're actively undergoing treatment for breast cancer, probably not a good idea. You know, definitely worth a conversation with the oncologist. And then for me, one of my kind of rules is like if they've had a blood clot in the last 6 months, I will usually hold off. There's no real data. There's no association in studies that show that there's a timeline between between blood clot formation and vaginal estrogen use. This is kind of just out of an abundance of caution. Other things that can have been shown to significantly reduce UTIs in women other than vaginal estrogen that are non-hormonal is fluids. In one study, they showed that women who drank less than 1.5 liters of fluids, not just water, fluids in a day with recurrent UTIs, they randomized them to increase their fluids or stay the same. And those who increased their fluids to over 2 liters a day, ended up being an average of 2.2 liters a day, they had fewer UTIs. They had about 1.5 fewer UTIs a year to 1.7 from 3.3. So for your patients that are not drinking, these are usually your older patients that really just not drinking anything, upping their fluids is a great way to reduce the number of UTIs, and also just something to keep in mind for patients who always, they get their UTIs around the time of travel or something like that. It's probably because they're fluid restricting. And it's very modifiable, low risk intervention. Other things that are fairly low risk are cranberry. The data for cranberry is becoming more promising. A Cochrane review from 2023 showed with moderate certainty that it does reduce the risk by about 30% of infections for UTIs for adults and children. This is in non-pregnant individuals. And mechanistically, this makes sense. We think it works because the cranberry contains proanthocyanins or PACs. You'll sometimes see that on some of the bottles, which inhibits the adherence of the P. fembria from the E. coli to the urothelium. So the one caveat with cranberry is that it really only works for E. coli prevention, E. coli UTI prevention. If you're getting UTIs from other sources of bacteria recurrently, probably cranberry is not going to work. And the AUA does say that it has about level C evidence. I think the more we study this, the more the evidence gets better. There is no proven dose that is helpful, and the data that goes into this Cochrane review is pretty heterogeneous. They just talk about cranberry consumption. That can be cranberry juice, cranberry supplements. There's a lot of different things that were studied, so I don't have a dose that I can give it to you. I tend to recommend cranberry supplements that are tablets that have 36 PACs, which is a higher end, or at least report the PACs, just because that is kind of what we're looking for. But, any kind of cranberry has some benefit per the Cochrane review. Theoretically, more cranberry would inhibit more. Other options that are not antibiotics are D-mannose. So this works by competitively inhibiting the bacterial adhesion to the urothelium via the type 1 fembria, preventing that. The studies on this are pretty mixed. Its use for prevention of UTIs is supported by AUGS, the American Urogynecologic Society. And so, I think that this is a good option for patients, especially if you're trying to maximize your non-antibiotic uses. Another good option is methenamine. Methenamine works by basically being hydrolyzed into ammonium formaldehyde into the urine. And so it creates a bacteriostatic solution within the urine, preventing infections. For me, this is great for patients who don't maybe fully empty their bladder. Maybe it's not so much that they need to catheterize, but they don't fully empty as well as you would like. This can be a great option. And another way to kind of maximize prevention without giving a ton of antibiotics. So just kind of in summary, when you are, encountering a patient who's had several UTIs or coming to you for recurrent UTIs, look at what the inciting events are. Is there something that's triggering this? Is this fluid intake? Is this sex? Do they have fecal incontinence that needs to be addressed? Are they wearing diapers for very, very long periods of time and not changing them? All of these things can lead to UTIs. Figure out what those inciting events are. My take is to always try to prevent as much as possible without using antibiotics. And so I tend to lean heavily, obviously, on vaginal estrogen. I'm a fan. I'll do cranberry supplements, they're very low risk. I'll do methenamine a lot. Really make sure that patients are drinking adequately. They need to be drinking those 2 liters of liquids a day. And I do let them know that, it doesn't have to be pure water. If they hate pure water, it can be something else. That study that showed increased liquids was liquids. It wasn't pure water. And then I also always put in orders for standing testing for these patients who have recurrent UTIs. They have orders so that they can, anytime they want, go to the lab and drop it off a urinalysis and urine culture. This helps the patient feel like they're not going to get lost. It also really helps your staff so that they're not dealing with patients just popping in and out, trying to drop off urine specimens and overwhelming your office. And it really ensures that you're getting the testing that you need so you can make sure that you're tracking resistance patterns, you're seeing if you're treating appropriately. And then, you can use those cultures to determine what antibiotic you're going to use. When do you, and so you can wait for the cultures to come back. I definitely let my patients know all the ways that they can use to treat their symptoms while we're waiting for the culture to come back, so they can kind of maximize their comfort while we're waiting for the culture, so we can help reduce the number of antibiotics that they're given.
Hopefully, all of these recommendations have helped y'all feel more comfortable and clear on when and how to help treat patients with recurrent urinary tract infections and what we can do to help prevent them. But I do think it's always good to kind of go over when should we be referring these patients out to urology for further workup. So patients who have recurrent UTIs who are on daily antibiotic prophylaxis and just aren't responding at all, despite being on multiple preventative measures and antibiotics, those would be patients I would refer to urology. They may need other imaging or cystoscopy. Patients with stones, I would just refer those patients to urology to manage those recurrent UTIs because the stones may need to be managed. Patients with upper tract abnormalities or bladder abnormalities, those are also patients that should be managed by urology as they can become more complicated and have more issues. And then another subclassification that either you refer out or you co-manage would be patients with multi-drug resistant UTIs. These are very common, unfortunately, but if you have patients with multi-drug resistant UTIs that are requiring IV antibiotics, I tend to refer those to infectious disease. Uh, our infectious disease colleagues have much better access to IV antibiotics and may help prevent these patients from needing to be hospitalized for IV antibiotics and possibly treated outpatient. So, one other thing that kind of needs to be brought up in a recurrent UTI lecture is asymptomatic bacteriuria. What is asymptomatic bacteriuria? It's the presence of bacteria in the urine when there are no urinary symptoms at all. There are certain times that we do treat this, mostly in pregnancy and also in patients who are undergoing urologic procedures that would disrupt the urothelium. Though these are two circumstances where it has been demonstrated that treating asymptomatic bacteriuria is helpful in improving patient outcomes. In the rest of the population, which is probably going to be the majority of the patients that you are seeing and treating, you do not need to treat these. If patients are not having symptoms and you just happen to get a culture that's positive, that is not someone who's requiring antibiotics. I would argue that if someone is not having any kind of symptoms, they're not pregnant, they're not undergoing a urologic surgery, you probably don't even need to be testing them, but you will probably get a couple of these urine cultures come across your desk in your inbox that you will see. But if they are not symptomatic, you do not need to treat them and you can just kind of watch and wait. In summary, for simple UTIs, we recommend a short course of antibiotics, 7 days or less. 14 days is not required for simple cystitis. Whenever you have a patient with symptoms, I recommend testing, even if you decide to not wait for the culture to result and treat empirically. Having the urine culture will let you know if you are in fact treating appropriately, and this is definitely key to managing recurrent UTIs. It helps us distinguish between if this is a new infection that is coming back or just an inadequately treated infection. Recurrent UTIs are defined as 2 or more UTIs in 6 months or 3 UTIs in 12 months. Trying to prevent UTIs is key, and we need to maximize our non antibiotic strategies that we have. Low dose vaginal estrogen is going to be one of the mainstays for many postmenopausal women. It definitely decreases the rates of UTIs in this population and is incredibly safe. Encourage adequate hydration in your patients and make sure that they are drinking at least 2 liters of liquids a day. And then also that we don't treat asymptomatic bacteriuria in the majority of the population, the exception being pregnant patients and patients that are undergoing urologic surgery should get treated. Everyone else, if they don't have symptoms, they don't need to be treated. These are the references for this lecture, and I hope everyone has a great day.